Hello, my name is Anna Norton. I'm a dentist specialized in pediatric dentistry and also a teacher at Faculty of Dental Medicine in the University of Porto in Portugal. It is with great pleasure that today I'm virtually present at this event to talk a little bit about a topic that I consider of great importance for professionals dedicated to the treatment of pediatric dentistry, which is the choice of the pacifier. I think for all of us child health professionals, the thought of using a pacifier causes a panic button to light up in our heads. But given the high prevalence of its use, in Portugal is about 70%. In South Africa, I did not find any prevalence described in the literature. It is very important that health professionals advise families about the best option to choose. Such important initiatives as World Health Organization Baby Friendly Hospital changes its guidelines in relation to the pacifier from avoiding its use to counseling families when their option is to offer the baby a pacifier. In other words, I think the message is that this is a subject that should be discussed with families. When we search in the literature, we find lots of problems associated with the use of the pacifiers, such as the nipple confusion phenomenon, the decrease in the duration of maternal breastfeeding, mouth breathing, and even obesity. We found several studies in agreement with the association of the use of the pacifier and the above-mentioned alteration, but other studies, namely meta-analysis, do not find a relation strong enough to seriously speak of a cause-effect. But I imagine that the major problem that arises in our minds are the occlusal alterations, namely the anterior open bite, an anomaly very easily identified and very much related to the use of the pacifier. But even in relation to the association between malocclusions and the use of the pacifier, the literature, namely the articles of great scientific value, such as meta-analysis, do not find a relationship that allow us to say in a peremptory way that there is a direct cause-effect. But of course, there are also aspects considered positive and important for the use of a pacifier, such as learning the sucking reflex, very important for premature babies, the role of pacifier in the preventive effect against sudden infant death syndrome, and the analgesic and soothing effect for the baby. Let us talk a little bit about the aspects to take into consideration when analyzing the different dummies on the market. I will try to describe the anatomy of a pacifier and consider the most important aspects. The first aspect to consider is the choice of material for the soother. In the market, there are two materials in which the pacifiers are made, latex and silicone. We must know the differences in order to properly inform families. Both materials have different characteristics. In latex, bacterial and fungal colonization is greater. The dimension stability of the material is altered by heat, and its physical properties changes throughout its use. In the literature, the risk of allergy or hypersensitivity to the material is reported. So, for example, in families with a history of allergies and atopy, this should be taken into consideration. As far as sucking is concerned, it is a material that requires less effort for the baby, and for example, in the case of premature babies, it may facilitate the learning of the sucking reflex. On the other hand, silicone does not absorb odors, nor does it suffer dimension alterations. The risk of allergy is not reported and demands a greater effort for the baby in order to suction in a satisfactory way. Naturally, what we want is that the baby has to make an effort to suck the pacifier in order to have the adequate muscular stimulus, as similar as possible to the stimulus that happens in the maternal breast. An aspect to be considered in this material is its risk of teething. This is particularly important when babies already have teeth. Parents shall be warned of the need to rigorously control the conservation state of the pacifier. Next, the shape of the lip shield is important to be analyzed. The lip shield shall allow the baby to have free nostrils to breathe and shall allow parents to quickly identify if the dummy is correctly placed in the mouth, because we don't want to run the risk of the baby putting the dummy upside down. For this reason, the shape which we consider most adequate is the heart shape. For babies with atopic skin, it is important that there is no accumulation of saliva between the pacifier and the baby's skin. In this situation, the option of an open shield is more adequate and more effectively prevents the appearance of skin lesions. Talking now about complications for the oral cavity resulting from the use of the pacifiers, and in what concerns the anterior open bite, what should we analyze in the pacifier teeth? The height of its base. In this image, we have two orthodontic pacifiers with completely different base heights. It is easily perceived that the risk of open bite is greater the higher the height of the base of the pacifier, as it favors separation of the dental arches of the baby during the use. The higher the base, the further apart the baby's arches are, the more serious the anterior open bite will be. And what about posterior cross bite? For better understanding, let's do a mental exercise. If we have a flat surface and we place a force point on it, we will obtain a deformity of this type. But if on the same surface we apply the same force over a larger area, a more uniform distribution of forces, we will get a deformity that is less severe. Transposed to the oral cavity, what we want is a balance of extraoral compressive forces produced by the perioral musculature and counterbalanced by the force exerted by the tongue on the palate. For this, it is desirable that the teeth of the suitor occupies the largest area of the palate to avoid isolated points of force in a smaller area, and that the tongue adapts as well as possible to the palate. It is therefore important to use increasing sizes of the teeth, so as to optimize the adaptation of the teeth to the surface of the palate. Also, the shape of the teeth should allow the tongue to go up towards the roof of the mouth while the child uses the pacifier. Therefore, it is important that it has its concave shape in the contact area with the tongue to allow it to rise. There are many clinical studies on this subject in the literature, but as it is a multifactorial entity, there is an unavoidable bias in clinical studies with a lack of objectivity. To try to obviate these problems, we resorted to computer simulation, where the risk of the bias is overcome and situations can be analyzed objectively. I'm very pleased to introduce my colleagues who develop all the computational simulation part of this work, Professor Miguel Nóbrega and engineer Rita Pereira, who has a master's student in biomedical engineer, did her master's thesis with this work. For the development of the work, a three-dimensional model of the maxilla was created from a maxillary cast of a 6-month-old baby. The tongue was also modeled, and the different colors you see in the image correspond to the main muscle groups. For a 6-month-old baby, we considered placing the 4 upper incisors, which are the teeth closest to eruption, and the first upper molar to study the behavior in the posterior part of the maxilla. In the first phase of the study, 3 different geometries were studied. I would point out that the only difference between the Suter-Collett standard and the orthodontic one is the thickness of the silicone in the contact area with the palate, which is smaller in the orthodontic one. In this image, you can see the model created, in which the various tissues have been included. mucosa, cortical bone, medullary bone, alveolar bone, periodontal ligament, and dental germ. The creation of this model is innovative and represents a huge advantage in the evaluation of the behavior of the pacifier, as all the tissue have different mechanical properties with different behaviors, and its gouging is very important in the proximity of the results to what happens in nature. In these videos, we can see the simulation of suction cycles with the different shapes of teeth. What we wanted to study was the distribution of forces on the surface of the palate, the force exerted by the pacifier on the palate, tooth displacement, and force exerted on the tooth. In this graph, we can see on a color scale the distribution of forces exerted on the palate. The red color represents the highest values. In these graphs, we can see immediately and quickly the difference behavior between conventional and standard and orthodontic soothers. As they did such a fantastic job that they were able to measure the movement of tooth germs. It is clearly noticeable the difference the behavior of the tooth germ when using a conventional pacifier and the other two. By seeing these images, it is easy to imagine that a tooth that is born when it is subject to this type of displacement is at much greater risk of being born already in altered position. In these images, we can see in detail the movement that all the teeth study undergo with the different dummies. Naturally, the force exerted on the teeth follows the displacement, and these graphs show exactly that. We can conclude, in relation to the different points studied, that in relation to all the tests, the results of standard and orthodontic pacifiers were superior in relation to the conventional pacifier, thus being possible in an objective way as never before tested, that in what concerns malocclusion, the use of the conventional pacifier potentiates its appearance. In a simple way, we can say that the greater the dental movement caused by the pacifier, the greater the risk of alteration in the position of the teeth, and the greater the pressure in the roof of the mouth, mainly if it is not evenly distributed, for example, greater pressure in the incisor area, the greater the risk of maxillary compression and anterior open bite. After this initial study with 3 pacifier shapes, we decided to continue to compare the behavior with other geometries. The next phase of the study was to compare with 3 more pacifiers geometries found in the market. Here we can see the simulation of sucking cycles and the displacement of the teeth and the tongue. They're quite different. In this picture, we can see very clearly the differences between the pressure and forces exerted on the palate in the different geometries. And what about tooth displacement? Let's watch these videos where the differences between the different geometries are clear. Also, once again, it is easy to gauge the clinical consequences of the displacements, and naturally, the smaller the displacement, the lower the risk of tooth malpositioning. In this image, we can see individually the displacement of all the teeth studied. So, the geometry of the pacifier F shows the higher displacements for all the teeth in this study. In these graphs with color scale, we can see very easily the differences in the results. Viewing these images was a very important moment for my clinical practice, and I hope it has the same effect for all colleagues who are viewing them. On this slide, we can see in a summarized way all the results of the tests carried out, and a ranking of the teeth cups according to their behavior was made. And for all the tests performed, there is no doubt that the teeth with geometry A and B, once again I reinforce that the only difference between these two is the thickness of the silicone in the contact area with the palate, obtained the best results in the tests performed. Thus, and based on these results, we can expect that the risk of malocclusion is decreased with the use of these geometries. I hope you have enjoyed the presentation, and I hope it has been useful for your daily clinical practice in advising families, knowing that, in fact, the choice of a right shape of the pacifier is crucial for the prevention of development anomalies of the oral cavity of the baby and child. Thank you so much for your kind attention.